Yes, good day, everybody. You're welcome to my YouTube channel once again, Dr. Kunle 23. Of course, my name is Dr. Adekunle Abiono, and today I want to talk about a topic that is special to my heart, a topic that concerns almost every woman on earth, fibroids, uterine fibroids. Statistics show that 4 in 5 women will have fibroid at some point in their lives. Statistics show that the women that have fibroid the most are the women between the ages of 30 above into their 50s. Statistics also show that out of the whole gynecological problems we have in women, fibroids make up over 60% of them. So you can see it's a huge one when we talk about fibroid. Today we're going to talk about the symptoms, we're going to talk about the causes, we're going to talk about some other very effective things, and I was able to gather some questions that I think I want to talk about too right here on this channel. So it will be interesting for you to stick around. If you haven't subscribed, click that subscribe button, click the thumbs up button, and also click the bell button so that you can get notifications whenever my videos come on. So let's get into it. So what is fibroid? Fibroid, also called myoma, also called leiomyoma, are benign growths. They are non-cancerous growths. They grow in the muscle of the uterus. They have different names. The names we give them usually depend on the location where they are. A fibroid is a fibroid, but where it is will determine what name we call it. We have the ones sitting inside the uterus itself. We call them the subserous. You see the ones, we call them submucous. Submucous sits inside the uterus. The ones that sit in the wall of the uterus, we call them intramural. The one that sits outside of the uterus, we call them the subserous one. You see. Then we have the subserous, the intramural on the wall, and the submucous on the inside. There's another one called the pedunculated. This one also is a subset of the one on the outside, but this time around they have like a peduncle, like a stalk, holding them, attaching them to the uterus. So pedunculated, And as I said earlier, the fibroid is not a cancerous growth, but howbeit, in as much as it's not cancerous, it poses quite some problem to most women. Trust me, it causes a lot of problem to many women, because of the symptoms it brings, and also the size. One interesting thing about fibroid is some fibroids can be nodular. When I say nodular, I mean very small, and then the person might not have any symptom. And on the other hand, fibroids can be as big as a watermelon. I've seen fibroids weigh over 5 kg before. I've seen women with fibroids, and when you see them outside, you think they're about 20-25 weeks pregnant. I've seen some, almost 28 weeks pregnant, and that's just a huge fibroid sitting in there. Even up till this morning, I got a call up till this morning, somebody who had sudden abdominal pain, and they had to rush out to a hospital nearby, and they did a scan and they saw massive fibroid. So it's very common. We see it almost every time. In fact, every time, especially within people of black race and also some Hispanic. So what are the symptoms of fibroid? So the symptoms range from person to person, but the commonest symptom we have is heavy menstrual bleeding. Your period comes 5 days, normally 5 to 7 days, some people lesser. Then the period comes, the first and second day usually is heavier, and then from the 3rd day starts stepping down. But in fibroid patient, right from the get-go, it becomes very heavy, and it's heavy almost all through. In fact, sometimes all through. That's one symptom. The second symptom is prolonged period. So instead of seeing your period for 3 to 5 days or max 7 days, some people see their own for as long as 2 weeks. Continuous bleeding heavily for 2 weeks. That's another symptom of fibroid. Pain pelvic pain, low abdominal pain, or feeling of pressure in the low abdominal area, that can also be a symptom of fibroid. When you have this urge to want to pee frequently, because the fibroid is sitting, the bladder is sitting in front of the uterus, and then because the uterus is bulky, it's pushing and pressing on the bladder from behind, so it makes the person want to urinate very, very often. So this person tends to urinate very often, sometimes little quantity, and in some people they find it difficult to even urinate, because of the same pattern. There's the blockage, there's pressure from behind and blocking the pathway for the urine to come out. In some people, constipation, same thing. If you have a big growth inside the tummy, it's going to press on every organ around that area. So sometimes it could press on the large intestine and cause constipation. Sometimes it could press on the bladder and cause these urinary symptoms we just spoke about. And also, if you are the kind of person that has menstrual cramps, you see that you have the menstrual cramp in the lower back area and also in the leg area, because of the position of the uterus. Then and the nerve supply. So then you see these people who have fibroids too, they have the same problem. Low back pain, they have leg pain, and it's so severe, sometimes they have to get to the hospital when this pain arises. Also, uterine fibroid, depending on the size, can also cause some form of reproductive issues. We've seen cases whereby people have problems, they have fibroid and they get pregnant, and then the fibroid starts showing them shege in the pregnancy. I've seen people who got hospitalized multiple times because of fibroid, fibroid in pregnancy. And I usually tell my patients that 3 things can occur when you have fibroid and pregnancy. First thing, the baby can starve the fibroid, and then the fibroid stop growing in pregnancy. I've seen that before a lot of times. And also, the fibroid can harm the baby and cause what we call a miscarriage. Depending on the size and position, it can cause miscarriage. And also, we've seen cases where fibroid and baby exist together. And then it causes a lot of pain and discomfort for the mother. Unfortunately, there's nothing that can be done. We just encourage the mother. We give painkillers. Sometimes, when we suspect that there's about to be a miscarriage or threatened miscarriage, the mother is admitted, placed on bed rest, given some medication to stop the contractions, given some painkiller injections, some muscle relaxants, just to make her relax and rest, and then send her home after a while. There's really nothing that can be done when the fibroid coexists in pregnancy except to give painkillers, reassure the woman as much as possible. Then also, when we talk of uterine fibroids, it's important to know what causes it, right? I think it's a gray area that people have really been very skeptical about. A lot of postulations, a lot of theories have come out to say, oh, this or that, oh, this or that. But then let's just crack it once and for all. What are the causes of fibroid? Number one cause of fibroid, is the hormones called progesterone and estrogen. These hormones feed the fibroid. That's their work. Fortunately, unfortunately, women live or thrive, or women are women because they have these 2 hormones. So in that case, nothing can be done really. When the hormones are there, there's a possibility that the woman can have fibroid. Also, we've seen that fibroid contains some genes that can make some how would I put it now? The genes in the fibroid tissue is different from the genes in the normal tissue. So there's some form of difference. So that difference is what makes the fibroid want to grow. And also, it's important to say that there could be a genetic factor to fibroid issues too, because I've seen cases where a mother had fibroid issues, she had surgery done. The daughters too also had fibroid issues and had surgery done. They see something called extracellular matrix. This extracellular matrix is a material that makes cells stick together, and we found out that fibrous cells contain a lot of this extracellular matrix. So that can be responsible for their growth and all. So also, one important aspect to also discuss is the diagnosis. How do you make a diagnosis of uterine fibroid? The diagnosis can range from one end to another. First step in diagnosis usually is physical examination. Many a times we have been able to diagnose uterine fibroid from mere examination. The patient comes in, lists her symptoms, and then as a physician, you are almost sure, oh, this is the case of your uterine fibroid. You just say, okay, madam, can you please lie down, let me examine you? And by the time she lies down for examination, by the time she opens her tummy and you feel the lower part of the tummy, you feel that growth there, and you are almost certainly sure that this is a case of uterine fibroid. Also, for better context, we can send them for a pelvic ultrasound. The pelvic ultrasound will now tell us the shape, or rather the size and the location of the scan, of the fibroid rather. It tells us the size and the location of the fibroid. Then also we can do an MRI in the case where you suspect that this fibroid is causing a lot of problems and there's pressure on the surrounding viscera, on the surrounding internal organs, let's put it that way. Then you want to know the exact shape and size and where exactly the fibroid is pressing on, especially when you are trying to walk the patient up for surgery, so you can do like an MRI, do an magnetic resonance imaging. Then also you can do what we call a hysteroscopy. Hysteroscopy is just like looking into the uterus from the cervix, using a probe, looking into it with a camera to see the exact size, or to look at the inner lining or the inner chamber of the uterus. Also, there's this procedure we do for women to check if their tubes are open, because when the fibroid is big, it can cause tubal blockage too. It can just obstruct the entrance of the tubes. And then if you do an HSG, then you can visualize to see if the tubes are open, and then see if there's a fibroid blocking the tubes there too. Yeah, so I mean, those are like the common ways to actually look at make a diagnosis of uterine fibroid. So I have a few questions here that I'll go through, but before I go there, let's quickly look into the management. How do we take care of fibroids? So I must say at this point that not all fibroids need to be removed. Yes, no surgeon, no gynecologist is happy to do a surgery, except when there is threat to life. When at that point you know that this patient will benefit from nothing else other than this surgery, then we send it. That's when we opt for surgical intervention. And of course, most of our patients come late, so at that point when they present, surgery is like the only option. So what are the treatment options? Yeah, so we can give some medication. Trust me, I know when people hear medication, their ear will stand, because I've seen a lot of people come to me with different type of medication, say, oh doctor, he said this medication shrinks fibroid. He said this medication shrinks fibroid. My dear, before a patient will qualify to take medication, there are some criteria the person must satisfy, or must have passed some criteria. So what are these medications? They are medication. I mentioned estrogen and progesterone earlier on. These are the hormones that make a woman a woman. So there are some drugs you can give to stop those hormones from being produced. Then that way there could be, it's not certain, there could be now the fibroid now shrinking. So which woman qualifies for that? As I said, those two hormones are the hormones that really make a woman a woman. So if you're taking those hormones away, we are sure that this woman, one, she's no more ready to have any children. She has had all her children, and then she's still having this fibroid problem. So there must be a problem before there's an intervention. So that's it. If there's no problem and this woman has had all her children, then she really doesn't need the medication. But for most other women that fall into the category of fibroid that needs intervention, there can be what we call a focused ultrasound surgery, where they use some high frequency sound waves to, remove the fibroids, from the outside. And this usually works for very small fibroids, usually fibroids less than 10 millimeters, very small, less than 20 millimeters, very small fibroids. That's what they can use them for. There's also some minimally invasive ones, uterine artery embolization, when you stop the blood supply to that fibroid, and then it shrinks the fibroid. When there's no blood supply, it now shrinks the fibroid. So that's also another method to use. Also, you can use what we call a laparoscopic or robotic surgery. For people who are familiar with laparoscopic surgery, it's just using a small keyhole. You call it a keyhole surgery, putting a probe inside, or 2-3 keyholes done, putting probes inside with cameras to operate this fibroid and bring them out. And this also, of course, is only applicable to fibroids that are less than the umbilical size, about 18 weeks size fibroid. Anything bigger than that, it really doesn't qualify. And also, hysteroscopic ones, where you go through the uterus itself, through the uterus. This one is usually done for the fibroids that are located inside the womb, not the one in the wall, not the one on the outside. So all these invasions have their pluses and they have their minuses. It's not a one size fits all. Then for the major surgeries, which we see most of the time because most of our patients present late, do abdominal surgeries where you remove the large fibroids from the abdominal area, from an abdominal incision. Or some women who haven't had all their children, they are not ready to have other children, or women who are not interested in having children at all, then they have this problem with their fibroid and it's huge. They will advise them to do a hysterectomy. That's to take away the uterus totally. So I have some questions here. Let me just go through them, and before we go into how to prevent it, because there's also a prevention part of it. Let's quickly run through. So this first question says, do I need to worry about a regrowth after a year? Right. So the regrowth rate. So I must say that over about 25% of people who have fibrous surgeries will have a reoccurrence, and let me rephrase. About 25% of people who have done fibrous surgery once will have another surgery done. That's about 1 in 4. Yeah, because there's a regrowth rate within 5 to 10 years. Not 1 year. This person's question said after a year. No, you don't have to worry after a year. But within 5 to 10 years, usually there is a regrowth. Then the second question says, what is the success rate of fibroid embolization? So for people that have had it, I've seen a couple of people have it. It's about 90%, 90 to 94, 75 to 94% is success rate. So it's quite successful. And as I said, usually for small fibroid, not for the large ones. So somebody asked the question: if a woman has had all her children without a history of fibroid, can she have fibroids after having all of them? Oh, the answer is yes. If she has not gotten to menopause and she's had all her children, she can have a fibroid. However, the rate of growth is not going to be as rapid as for a woman who does not have any children, because the saying goes that when the uterus is empty, not carrying anything for a long time, it gives room for fibroid to grow. Then I got another question. She said she has had fibroids in her pregnancy that made her have CS in all her pregnancies. And I must say, when fibroid coexists with pregnancy, usually, not in all cases, but usually the woman has to do a cesarean section, especially if the fibroid is growing in lower segments. So they will have a cesarean section. And when during the cesarean section, the surgeon cannot remove the fibroid during the cesarean section. I've seen some highly skilled surgeons do some highly powerful maneuvers, but we do not advise that you remove a fibroid during cesarean section, except of course the fibroid is right in your way, is not allowing you access the baby, then okay, then that is usually excusable. So this woman has had all her children, and then she had 3 CS, and she's asking that now she's having heavy menstrual flow, and what should she do? What I would say is, with your heavy menstrual flow, you can see your gynecologist, let them do a blood check and see how much your blood level is, and see how dangerous the size of the uterus of the fibroid is compared to your symptom, and then they can make a diagnosis from there to see if you can put you on watchful waiting list or outrightly do a myomectomy. Right. So how can we prevent? First thing is to maintain a healthy weight. People who have a high BMI are prone to having uterine fibroids, and also a healthy diet, which is rich in fruits, vegetables, and grains, whole grains, can also help to lower the risk of uterine fibroid. Another thing, healthy living and good stress management, are also techniques to use to prevent fibroid. From all I've said, it just goes to show that taking care of your body and your mind intentionally can help you manage fibroid. And for people who have had fibroid surgeries in the past, who are looking at because you've had that fibroid surgery, you're looking at, okay, how can I live so that I won't have a recurrence? If you place yourself on a healthy diet, if you do regular exercises, watch your weight, and come under a good BMI, yeah, I think you can make it without having another surgery. Well, that's it for now, folks. I'd like to hear your comments and your suggestion here in the comment section. I'll be waiting for you there. Join me again sometime soon. We'll bring you another topic, another interesting topic. This is your guy, Dr. K. Bye for now. Thank you.